appreciate this. The beauty about being here is you get to understand when you go to the doctors, what do they mean with all the big terms, as they're examining you. When they just say, you've got a nice trilaminar, at least now you can, understand because you've been to these exhibitions and you have the opportunity to actually go and talk to Dr. Tasneem and ask him and understand, which is something that you probably would not have when you go visit your doctor. And our next speaker, before we go any further, Dr. Tasneem also just mentioned it, that infertility is not a woman's problem. It's a couple's problem. And year on year, I realize that we have more couples than just ladies coming to the shows, which is a beautiful thing to watch. Thank you guys, because the reason why we have Fertility Show Africa is because it is a problem in Africa that it's always looked at as a woman's problem more than a couple's problem. And we learn, we do better. Dr. Jack Biko is a reproductive medicine specialist and a consultant at the Reproductive and Endocrine Unit at Pretoria University. He is the current president of SASREG and the medical director of Femicare Fertility Center in Pretoria. Dr. Biko is passionate about advanced gynecological endoscopic surgery, endometriosis, and management of endocrinology.
Good morning, ladies and gentlemen. IFASA, thank you for having us here. This, like Tasneem said earlier on, infertility is a major, major problem. So if you go into social media, you're going to get a lot of information about infertility. Unfortunately, most of it is not correct. Now, bodies like IFASA are there to correct the misconceptions about IVF and infertility in general. So it is great that IFASA has seen the need to partner with us as SASREG. Now, SASREG is a body of accredited fertility clinics in South Africa. You'll understand that infertility is a disease, and every disease requires treatment. But there are various treatment options for the various diseases. One of those options is IVF. So I'm going to talk about one of the options in the management of infertility. Thank you. And that option is IVF. So what is IVF? So now IVF is a process that involves collecting eggs from a lady and then fertilizing those eggs outside of the body. So we take the eggs from the lady and we get the sperms from the partner, from the male partner, and then in the laboratory, we fertilize those eggs. This process is also called the test tube baby. So the impression people often get is that we make little babies like this and put them in tubes like that. It's not exactly like that, it's just an idea, but it's more like this, where we take microscopic cells, an egg is a cell, it's a one-cell structure, and we mix it with sperms or we inject sperms into it to do a process called IVF or ICSI. And this is a process that we do in couples who would otherwise not be able to conceive naturally. Now, reasons for IVF, like the previous speaker said earlier on, there are many, many reasons why we do IVF. She has gone into the details in the causes of infertility. I will just mention a few common ones that we see in our country. Blocked fallopian tubes. If the tubes are blocked, there are only two ways that the patient can fall pregnant. The first way is by doing IVF. So if you do IVF, you bypass the tubes and you make the baby outside of the fallopian tube. Remember, the babies are not made in the womb, they're actually made in the fallopian tubes. So if the tubes are blocked, it means you can't make the baby, therefore we have to bypass the tube and do IVF. The second option is to do surgery and to fix those blocked fallopian tubes. But not all tubes can be fixed. We have guidelines that will help us in determining which tubes can be fixed and which ones cannot be fixed. So we can know all of those things before the surgery. We can determine whether you qualify for surgery or if you don't qualify for surgery. The second common cause, and one of the most common causes in our clinic for infertility, is advanced age. Now, when women are born, they are born with all their eggs, and they don't form new eggs anymore. This is unlike males. Now, in men form new sperms every 3 months. So every 3 months, men form new sperms. But the ladies, once you are born, you don't form new eggs. And as you get older, the quality and the quantity of the eggs decline. And that decline of egg quality and quantity becomes more rapid after the age of 35. So once you've reached 35, that's why Dr. Taslim said earlier on, you can't wait, try for another year, because you don't have a year. We give you a maximum of 6 months to try to fall pregnant. If within 6 months of trying, you haven't fallen pregnant, you have to go see a fertility specialist, not your GP, not your gynecologist. Now, men with subnormal sperms also may require fertility, and all those men who can't produce sperms where there are no sperms, in other words, for whatever reason, either the male tubes are blocked. Remember, men also have got tubes. Ladies have got 2 tubes, one on the right, one on the left. Men have got about 6 tubes in total. So we've got more tubes than ladies. So if those tubes get blocked again, we will have to do IVF ICSI. And then some patients do not have eggs for various reasons. Either they were born with a genetic disease that make them lose their eggs rapidly, because remember, every month you lose your eggs every month. Whether you see your periods or you don't see your periods, whether you're using contraceptives or not, you will be losing about 20 or more eggs every month. So some patients, the rate of egg loss is so fast that by the time they reach a certain age, 30 or whatever, they've run out of eggs for whatever reason. Previous surgery to the fallopian tubes, to the uterus, previous endometriosis surgery can also make patients run out of eggs. And then certain kinds of chemotherapy and radiotherapy, those patients with cancer, once you get chemo, it burns the eggs, and then these patients can run out of eggs. So those patients will require IVF. What we normally do for the patients with cancer, they get sent to us before they get chemotherapy, before they get radiotherapy, so that we can take out their eggs and freeze them. And then they can have their chemotherapy and radiotherapy. After the chemotherapy, when they're in remission, we have their eggs, we can get them pregnant again with their own eggs. Endometriosis is very, very common, affects 1 in 10 patients at least. And the higher stages of endometriosis, stage 3 and stage 4, those patients usually do not conceive spontaneously, because with stage 3 and stage 4 endometriosis, the tubes are often blocked. They've got horrible endometrioma, and therefore, in general, most of these patients will only conceive if they either have proper surgery or if they undergo IVF. Now, polycystic ovary syndrome is also a fairly common cause of IVF, but the reasons are a bit different here. So when patients have got PCOS, the eggs are a bit lazy, so they don't ovulate, they don't grow appropriately, and they don't ovulate. So you go to us, to the doctors, to give you medication to stimulate the eggs to grow. And many a times, instead of growing 1 or 2 eggs, you get an outburst of many eggs. You get 10 eggs or 8 eggs growing together. And if you do that, you can't go home and have intercourse. It's too dangerous. You're going to fall pregnant with 10 babies. So what we do in that case, we then convert the cycle from a normal timed intercourse or IUI cycle. We convert it into an IVF cycle because it is more controlled. Then we take out those eggs, we make the babies in our test tubes and transfer 1 baby only. This is to reduce the risk of multiple pregnancies, which is a major problem at the moment. And then certain genetic conditions, it is important that we do IVF, because with IVF, we make the babies, and then we do PGT. We test the babies before we put them back into the womb. Then I know exactly what baby I'm putting back in the womb to make sure this baby doesn't have this particular disease that's there in the family. So IVF and PGT is the way that we are doing stuff these days in those patients with genetic conditions. The WHO says that infertility is a disease, but I'm here to tell you that it's not just a disease, it is more than a disease. You will see that, for instance, in Nigeria, women who cannot fall pregnant, women who cannot deliver babies, when they die, they are not allowed to be buried in the graveyard of the society because it is said that they're going to make the area to become sterile and the crops will not grow. So it's a major problem. Depression is a big country. They've done studies in this country which show that ladies or patients, couples with infertility, suffer major degrees of depression. It's a serious problem. And the doctors who deal with these patients know this, and that's why most fertility doctors are very kind people. They understand the situation because it's a big problem. It's not only about infertility, but it takes a major toll on the well-being of society and couples. It's not new. We've been trying to do this for many, many years. In fact, in 1943, hormone supplements for fertility were developed because already then there was a problem with infertility. And the management then was different. In the early 90s, families used to be together. If there's a fertility problem, then the brother would help or somebody would help. Of course, these days it's difficult to do that. So but families used to make a plan those days. In the 50s, IVF was tested in mice and rabbits. And then in the 1960s, we developed drugs to boost fertility, things like Clomid, which everybody has been on. And then in the early 60s, the first time human eggs were retrieved and fertilized. And then in 1978, the world's first IVF baby was born. Now, this was a breakthrough in reproductive medicine and health. And for this breakthrough, Edwards got a Nobel Prize for medicine because now couples could, for the first time, have babies. Couples who would, under normal circumstances, not have babies. Now we had the ability to assist these couples to fall pregnant. So the progress in IVF is that success rates have increased. When we started many, many years ago in the 70s, success rate of IVF was 4%. So you had to do 100 girls to get 4 girls pregnant. And then there has been improvements in medications. Drugs have become safer. We've gotten better in our ability to manipulate the physiology of the reproductive system. We've become better to manipulate the sperms and the eggs. We have developed new technology in our laboratories to the extent that currently success rate of IVF has gone up from 4% to just under 50% in the younger patients. All right. So the younger patients, we got a very good outcome. And the older patients, obviously, the outcome is good if they use younger eggs. We'll talk about that now. So how is it done? For those of you who still have to undergo the process, and those who might have to undergo the process, this is how we do it. You're going to see the fertility specialist, or your doctor will refer you to a fertility specialist. If you're above the age of 35 years old, we recommend that go straight to the fertility clinic. Don't bother going to the GP or the general gynae because you don't have the time to waste. You must go straight to the fertility clinic. They will consult with you. They will take a history as mentioned by the previous speaker. You will have an examination, general and specific examination, and then there will be targeted investigations. The aim is to see what is the problem so that we can make a diagnosis. Remember, there are many causes of infertility and there are various treatment options for fertility. Not everybody requires IVF. Some might require insemination. When I say IVF, I mean IVF and ICSI. I'll explain the difference later. So there are different things that we can offer our patients. In our clinics, in the SASREG accredited clinics, we recommend that all our partners, all our members must offer our patients psychological counseling. So all our clinics will have a psychologist on site or a psychologist who's accessible to the clinic patients, because it's very important. The emotional drain of infertility is hectic. The physical drain is hectic, and the financial drain is extremely hectic. And then once that has been done, the doctor will then decide on a protocol as to what type of protocol we should do to grow your eggs. Now remember that every month there's about between 5 and 20 eggs that start growing every month. So let's say your period starts today, you can have 20 eggs that start growing. And then after about 3 days, 4 days of your period, one of those 20 eggs will become the dominant egg. And that dominant egg will then produce chemicals to destroy the other 19 eggs. So your one selfish egg will destroy the other eggs. And then only one egg is going to grow. So when we do IVF, when we decide on a protocol, we give you medication that will start on the 2nd day or the 3rd day of your cycle. The aim of that medication is to stop the dominant egg from killing the other eggs, because we want all those 20 eggs or 10 eggs to grow together. We grow them all together because we want to harvest them together. I don't want to get one egg after a cycle. I want to get as many eggs as is possible and as is safe for that cycle. So then we're going to get monitored. Dr. Tasneem showed you the ultrasound pictures. We know exactly where you are in your cycle. We look at the eggs, how many are they, and the size, and we look at the lining of the womb. There has to be a correspondence between the two in most cases. And then once we reach the right size of the eggs, we then trigger you, and then we admit you to our IVF labs or to our hospitals to come and take out the eggs. Now there's a picture there of an ultrasound. We take out the eggs through the vagina. There is no surgery involved. So we give you deep sedation. The patient sleeps because it's a painful process. And we take out all those eggs. Now the eggs that we take out doesn't mean that you have run out of eggs. We take out the eggs for that month. Your body will only release eggs for that month. Every month, the body will make certain number of eggs accessible to us. The eggs for next month, we can't see them, so they're not accessible. Whatever I take out will not affect your future fertility. And it's important that donors must understand this as well, because donors often ask us, now if I donate my eggs, what's going to happen to my future fertility? Then we tell them that if you don't donate those eggs, you're going to lose them in any case, because you won't use them. All right. So we take out the eggs, and then we use a vacuum pump there. And then from there, these eggs are mixed with the sperms. We'll talk about that later. And then we get the development of these little embryos. And usually after 5 or so days, we'll then transfer one embryo back into the womb. Occasionally, we'll transfer 2 embryos back. Now, in our society, which is SASREG, we recommend that only 1 embryo be transferred if we have good quality embryos. If the quality is very suspect, we might transfer 2 embryos, because we know the risk of twin pregnancies to the mother and to the child are quite hectic. All right, once we've made the embryos, we can then decide to test them. We do PGT if we so wish, or if it's a genetic disease that we're worried about. We test the babies, and then before we transfer them, and then we then freeze the babies, and then transfer them later after we get the results. So if I got 10 eggs, I'll end up maybe with 4 or 5 embryos. We transfer 1. The remaining ones, we freeze them for future use. So in diagrammatic format, you consult, you see an IVF specialist, we do the test, you get the stimulation, we take out the eggs, we get the sperms, we make the embryos, and they grow, we transfer them, and then about 10 days later, you do a pregnancy test. Now, it is important to note that embryo transfer is the last stage whereby your doctor's got control over the situation. Once the embryo has been transferred into the uterus, we have no control. It's between the embryo and the uterus. The uterus is alive. they talk. The uterus and the embryo talk. It's called crosstalk. So the baby and the womb talk. They must talk and they must understand and agree on terms. If they don't agree on terms, then the womb is going to reject the baby, and you're going to lose the baby. And as doctors, there's nothing we can do about it. Usually, a normal embryo will secrete normal chemicals. The womb has got receptors for normal chemicals. An abnormal baby will produce abnormal chemicals. So if these chemicals come to the womb does not have receptors for those abnormal chemicals. It's like a key and a lock. So the key must fit the lock. If the key doesn't fit the lock, you can't open the door. If the embryo doesn't secrete the right chemicals to the womb can't open the door, and the baby cannot go and stick inside the womb. So very often, patients with recurrent implantation failures, often there might be a problem with the baby, that the baby is abnormal. That's why we do PGT for those patients with recurrent implantation failures to see if there's no problem with the babies themselves. Now, IVF is common. Infertility is very, very common. When patients have got sugar diabetes, high blood pressure, it's easy to say, no, I've got hypertension, I'm on medication. But it's not easy to say, oh, sorry, I've got infertility, I need IVF. We don't talk about it. But in truth, it is extremely common. We say that about 1 in 6 couples will require our services. And IVF and infertility in particular does not discriminate against anybody. It affects the poor, the rich, the well-known, and the unknown. This couple here, they have their babies through IVF. The former president of the USA, they've got their 2 kids through IVF. If there was no IVF, they wouldn't have had children today. So we are all in the same boat. IVF is just a disease, just like any other disease. And we are very glad that Discovery Health has come on board to recognize that IVF or infertility, just like sugar diabetes, is a condition that requires treatment, and that they were very happy to agree with IFASA and with SASREG when we approached them to say that please reimburse our patients. And Discovery Health has been on board for more than 3 years now. I can tell you now we had discussions with a number of medical aids to come on board. Some are still promising. Some tell us that but the patients with infertility are not going to die. Why should we bother? So we need pressure societies like IFASA to put pressure on these medical aids, whilst we as professional bodies also put pressure on them because it's a disease that requires treatment. And you pay your medical aid, so they must reimburse treatment for IVF. It's not always rosy. My IVF experience didn't end with a baby. Unfortunately, that is rather too common. I have to be honest with you. The majority of patients who undergo IVF will not succeed. And there are many reasons why. Like I said, one of them is we can grow what you have. We can take out the eggs that you have. We cannot improve the quality of the eggs. If the egg quality is not great, if the sperm quality is not great, we cannot make it great. We work with what we have. If what we have is what we have, that's it, what we have. And secondly, we've got no control as to what's happening inside the uterus, between the uterus and the embryo. We can operate to make sure the fibroids are gone. We follow up the uterus, we follow up the patients. But at a deeper level, we have got no control. So we cannot guarantee any success. In the UK, the government, NHI, pays for 3 cycles of IVF. 3 cycles, because they are aware that 1 cycle doesn't always work. And when I read the latest information is that they are trying to pay for 6 cycles, because some patients take more than 3, 4, 5 cycles to fall pregnant. I know those couples who've had unsuccessful cycles, you ran away from your clinic, you went to another clinic. Believe you me, it's not your clinic's fault. The clinic guys will often be nice and say, sorry. They say sorry because they are concerned, not because they made a mistake. It's not their fault. It is just how life is. So IVF, no guarantees. We just do the best we can and pray and hope for the best. So, because it's such a common problem, every doctor will say they can do it. All right. Now, in this country, there are two types of fertility clinics. There are those which are accredited, and there are those which are not accredited. Now, they do whatever they want to do. Now, I'm going to recommend that if you go to your IVF clinic, please go to a SASREG accredited clinic, because all those clinics which are accredited, they have to hand in all their data to the central registry. We know exactly what each and every clinic is doing. We know how many patients they are doing. We know what protocols they are using. We know what are the outcomes, success rate. We know how many babies were born. We have all the data. So only clinics that are prepared to do the right job, to provide their stats, are allowed to be part of this society. So we've got guidelines in this society as to how things should be done. So I'm going to give you some of our data of our society. So now, if you look at our data, the causes of infertility for IVF, okay, let me quickly explain IVF and ICSI. Now, IVF basically is a completely natural process. It's completely natural. We give the lady medication to get the sperms, the eggs. Those are the eggs. And then we take the partner sperms, we put them together, and then we go away in the lab to incubate. And then the sperms will have a fight to determine which one is the best sperm. And then the best sperm will go inside the egg and fertilize the egg. That's IVF, completely natural. ICSI is different. Our staff, the embryology team, will look at the sperms and decide which is the best sperms. They've got criteria to determine on that. And then they will then take the best sperm and inject the best sperm there. Basically, it's nature versus human. Which is the best, I don't know. So there's a difference, but we use it as one term. So if you look at our data, SASREG clinics data, if you look at IVF, causes of IVF, in 34% of cases for IVF, it was female factors, tubal factors, blocked tubes. 34% of cases, blocked tubes. The rest were not blocked tubes, were something else. If you come to ICSI, 32% sperm problems. So in total for IVF, it's 30% female, 30% male. So that's why it's important when we talk about IVF, we talk about a couple issue and not my problem or your problem. It's a couple problem. Now, what are our data? Because we have to compare ourselves to international standards to see where we lie. If you look at the 2014 data, we had about 5,000 aspirations, which is 6%. 6% of patients with infertility in South Africa have access to fertility clinic. Only 6%. 94% of our patients do not have access to fertility clinic. That's a sad reality. And we have those where in South Africa, a pregnancy per aspiration rate of 33%. And the live birth rate per pregnancy of 48.2%. If you compare to the USA, pregnancy per aspiration is 36.8%. So if you go to your clinic and they tell you that we've got a 100% success rate, it's not correct because it's impossible. All right. So even the first world country, it's not that great. All right. Japan, where's that? And then look, pregnancy per aspiration. What happened to Japan? Gee. Oh, okay, sorry. But anyway, live birth rate, 48%. Japan was better with the live birth rate, and the States was very good with live birth rates. And the States at that stage did PGT before we did much of PGT. Now, if you look at the 2019 data, which we also have, if you look at this, most of our cycles are fresh cycles. In other words, we stimulate the patient, we take out the eggs and transfer the embryos fresh. So most of our cycles, about 50% were fresh, and then the rest were frozen, whereby we do the IVF, we put the eggs away, we freeze them, and then a month or 2 months later, for whatever reason, we put them back. So about 50% fresh cycles and about 50% frozen cycles. And then delivery data, if you look at this, most of our babies are singletons, which is excellent. We want this value to be more than maybe 85, 90%. Our twinning rate is about 21%, so it's still high. Remember, twins I know patients love twins, but for doctors, a twin is a complication. So our complication rate is about 20%. This is bad. Triplets is really, really bad because these kids get born at 30 weeks. They go to ICU for 3 months, 6 months. They develop brain problems, gut problems. So we don't like twins. As a rule, we are happy with this. This is acceptable. This is not acceptable. Now, I said earlier on that sometimes patients have got no eggs for whatever reason. And I can see that our egg donation cycles, we're getting good outcome, irrespective of the age of the patient. Whether you are 60 years old or 40 years old, whatever, we're getting this good outcome because the success rate of IVF is determined by the age of the eggs, not the age of the uterus. So it's very nice success rate for those who are undergoing egg donation cycle. So in conclusion, when we do IVF ICSI, we choose the best quality eggs and sperms. But remember, IVF cannot generate new eggs. If you don't have eggs, you have to use egg donation. IVF cannot improve the quality of the eggs, and thus success rate of the IVF is determined by that quality of the eggs. However, it is now possible for almost all couples to have a chance of conceiving because if you don't have eggs, you've got egg donations. If you don't have a uterus, the surrogacy. There's always something that can be done. Egg donation cycles and sperm donation cycles have got a very, very good outcome. And finally, ensure that your IVF cycle is done at these clinics. You'll see these are centers of excellence that apply best current practice. And they all are members of our society called SASREG. Thank you very much.